All right, good evening, everyone. My name is Sandra Lewis, and I'm the VP of Marketing and Communications at NeurAbilities Healthcare. I want to welcome everyone tonight to our webinar on developmental milestones and indicators for interventions, presented by Dr. Madeline Chadehumbe, and she's the head of the Division of Neurology and Developmental Pediatrics at NeurAbilities. Dr. Chadehumbe recently joined us and our team in August and oversees all of our medical providers in our three medical locations. And we're just thrilled to have her leading our medical team as we support patients and their families, school districts, and other community providers to find solutions and answers to their neurological, developmental, and behavior concerns. Viewing childhood as a journey full of possibilities, Dr. Chadehumbe strives to help each child become the best possible version of themselves and recognizes the importance of providing evidence-based and interdisciplinary care. Dr. Chadehumbe is triple board certified, specializing in pediatrics, child neurology, and headache medicine. And while she cares for patients with a variety of concerns, she has special interest in providing treatment for patients with self-injurious behaviors and autism and neurodevelopmental disorders, headaches, dysautonomia, 22q11.2 deletion syndrome, and epilepsy. As an advocate for children, Dr. Chadehumbe sits on the boards of several groups to share her voice and drive action, including most recently the Child Neurology Foundation. She's also a recipient of the A.B. Baker Teaching Award by the American Academy of Neurology. Thank you, Dr. Chadehumbe, for being with us tonight. Before I hand over the microphone, I would like to address just a few housekeeping matters. We're going to ask that everyone keep your microphone on mute throughout the webinar, but Dr. Chadehumbe will address questions at the end of the presentation, and you are welcome to add your questions to the chat as we go along, and be aware that she might also ask some questions of you throughout the presentation, and you are welcome to add your answers to the chat. So without further ado, please join me in welcoming Dr. Chadehumbe.
Thank you so much, Sandra. I just want to make sure that everybody can hear me before I get started. Fantastic. Thank you again for this warm welcome. And of course, it's such a pleasure to get to speak to all of you. I hope I will be able to share something new, and hopefully I will learn something new from you all as well. So at this time, I have no disclosures as they pertain to this talk. And I'm hoping by the end of the talk that each of you will be able to recognize some common and early red flags associated with autism, hopefully describe how these early flags affect communication, social, and patterns of behavior in young children, as well as having some next steps, not only for family and caregivers, but also for educators when they display or see children that display these symptoms. So what is autism? Autism is a neurodevelopmental disorder that's associated with challenges in social skills, repetitive movements, behaviors, speech, and nonverbal communication, and it adversely affects a child's educational performance. Other characteristics that are associated with autism include resistance to environmental change and changes in daily routine, as well as unusual responses to sensory experiences. So the three main areas that are associated with autism are going to be communication, social interaction, and restrictive interests and patterns. I wanted everybody to sort of pause at this time and just remember that children on the autism spectrum may display exceptional skills in certain areas, but what we're looking for specifically is the area of communication, social interaction, and restrictive interests and patterns. When we think about autism, it is a spectrum of disorders. And so it is not one thing, it is not one clinical condition. And in general, you might hear people speak about ASD or ASD level 1, 2, and 3, which really helps providers understand the severity of symptoms. With level 1 really correlating with the old term Asperger's syndrome. I think most of us will have heard that term, which may include symptoms such as difficulties with initiating social interactions, perhaps challenges with organization and planning, and that might hamper somebody's independence. With level 2 or requiring level 2 support, oftentimes there's narrowed social interests and interactions, and there's often some restricted and repetitive behaviors. With level 3, there's often severe deficits in verbal and nonverbal social communication, and oftentimes there's great functional challenges as well. When we think about the prevalence of autism, this is a schema that looks at all of the states and provides us a guide to see that there's areas, especially along the Northeast, that have a higher prevalence of autism compared to areas in the middle and south. We're looking specifically at New Jersey. According to the CDC, in the US, 1 in 59 children has been diagnosed with autism. However, in New Jersey, we know that 1 in 28 boys has autism, and in general, 1 in 36 children have autism, with an estimated annual growth of 10 to 17%. It's important to know that every community is affected, all races, all cultures. And so this is really important as we speak about some of the disparities that exist in the diagnosis. So most commonly, the early signs of developmental differences may be noted as early as 12 and 18 months, especially if a child has not experienced any particular regression. Oftentimes, parents will report that there's a plateau in development. However, about 30% of kids will have symptoms that appears to be closer to 24 months. And with that, sometimes there is a reported developmental regression or a loss of skills. The symptoms can be present as early as 6 months in very keen and acute parents and providers. And certainly it is important that we are recognizing the symptoms as early as possible. On average, in the US, ASD is diagnosed somewhere between 3 and 4 years of age, and it has been found that intervention is greatest and the impact is greatest when we can find these children before the age of 3. It takes on average 1 to 2 years for a child to get diagnosed, and certainly greater in communities that are marginalized. Before you start to understand what the red flags are, it's important to at least have a roadmap of what is considered to be normal development. So at 6 months, children should be able to copy the sounds that a parent is making. At the time they're about learning to sit and perhaps learning to crawl, they're able to make their mouths do what your mouths are doing, so making similar sounds, shaking their head when you shake your head, and certainly responding to their name, smiling when they see you, and having that eye gaze or eye contact start to develop. By 12 months, children should be able to copy gestures, waving bye-bye, let's clap your hands, responding to simple requests like let's play peekaboo. So those kinds of things start to become apparent closer to 12 months of age. And at that time, most children will start to say their first words. At 18 months, they're starting to string several words together, maybe having a few phrases. Again, they are starting to be able to mimic play, take a doll, pretend that the baby is crying, things like that, and show interest in different toys at about age 18 months. By 2, they're able to usually speak in 2 to 4 word sentences, able to follow instructions, kick a ball, point at things that they want, show mommy, look, this is, when they're out in the community. At age 3, they're wanting to copy what other kids are doing, and perhaps copy what even adults are doing, and can usually carry on a sentence or a couple of sentences at a time, and they're able to really have good motor skills by that time. They should be able to play make-believe, hide and seek, those kind of concepts start to be normalized at age 3. And by age 4, they would rather play with other children rather than playing on their own. So these are just broad strokes in terms of understanding what a normal childhood development looks like. Some of the signs that we will start to appreciate when you identify a child with autism, we're going to go through those, and so you'll be able to really understand them, but this is just a picture schemata. So we talked about between the birth and 12 months. If the child is not really providing you what we call joint attention, and I call this the mom look sign, so they're able to point at things and they want you to look at them with you. If they're poorly socially oriented, which just means that they're not able to recognize when a caregiver that is very familiar to them enters the room, this would also be a red flag. If you're not appreciating any babbling, you're not appreciating any vocalization, and there's just a limited range of sounds. They're not pointing, they're not using their nonverbal communication, and they just seem out of sync with really either excessive or very low attachment to their caregivers. Having an inconsistent or lack of a social smile, and not responding to their name by the age of 12 months. Difficulties with imitation, waving bye-bye, poor integration of both verbal and nonverbal communication, trying to copy the sounds that your mouth is making, having an unusual fixation to certain objects, and really having a hard time breaking them from the fan or the ceiling that keeps going around and around in the room. It's often hard to pick it up at this age, but really are pointing these out for individuals who may start to kind of see those symptoms, and they would like to talk about them with their provider. More commonly, though, children present between the ages of 12 and 36 months, mostly because speech is one of the first reasons, or one of the common reasons why children get evaluated, or at least they start the evaluation process, because they haven't had these single words by age 16 months, and there's no two phrases by the age they're 24 months. Continuing lack of a response to their name becomes a concern. And then poor coordination of the eye gaze and poor development of nonverbal gestures, and avoidance of eye contact, the use of repetitive words and phrases over and over and over, the lack of functional play, so not being able to feed a dolly or see a doggy and really know what to do with an animal, for example, the lack of shared enjoyment on common activities, playing peekaboo should be one that children enjoy doing together, having a limited repertoire of play activities, such as obsessive interest and lining up of toys repeatedly. At this time, you might see some repetitive movements like hand flapping, spinning, spinning around in circles, rocking, and they could be some loss of language or social skill loss at that time. I would like to have an audience response question at this time. So I would like you to pick out the one that is incorrect. So most toddlers with autism have the following: impaired conversation, adherence to a routine, delayed or impaired joint attention, and stereotyped language. Only one of these things actually is true. So most toddlers with autism have one of the following: impaired conversation, adherence to routine, delayed impaired joint attention, or stereotyped language. Of these four, which one would you pick as a red flag to consider talking to your provider about autism? I'm going to have Sandra or Matan give me the most popular answer in the chat, so I can move to the next slide once I know what people are thinking.
So far, C.
Okay, C is absolutely correct. So well done, everyone. It's important to recognize that there's a lot of reasons where children can have speech delays, for example, and it does not mean the child has autism. So it's an important demarcator to not have the child have that ability to have joint attention as one of the sentinel markers. So in general, it seems when we are diagnosing children, or at least evaluating children with autism, parents are more likely to point out abnormal behaviors than they are to point out abnormal social interactions. And so I really want to stress the importance of looking at children's social interactions more so than their behaviors, like having excessive tantrums are common ones why people may come for an evaluation, having hand flapping or stimming, having excessive hyperactivity, excessive sensitivities to sound and loud noises and crowds, and speech delay tend to be the most common. I want to show a short video clip so you can appreciate some movements you might see. Don't worry about the sound. I'm not really trying to show or have listened to the sound. But you're going to see a group,
Child will repetitively
multiple children
flap his
doing
arms,
certain movements.
wave his arms. He may also jump or hop while doing these movements. Other children will put their hands in front of their face, wiggle their fingers. They may turn their wrists outward and wiggle them. Again, these are repetitive movements that you will see on an ongoing basis.
So I love this video because it shows a number of children who display stimming. And so the question I have for the audience is that all children with trouble with transition, as well as who display stimming behaviors and echolalia, have autism spectrum disorder. Is that true or false?
Looks like false is the winner.
False is the winner. So it looks like everybody here really understands that there's a lot of individual symptoms that you might see in children. And actually, we see more normal children with stimming than we do children with autism. Yes, autistic children on the spectrum tend to have stimming as one of their behaviors, but it's not necessarily on its own a symptom that a child may be on the spectrum. So I get asked this question a lot, so I thought it would be helpful to see a couple of videos. So developmental delay does not equal autism. And the important things to recognize, or the things that you want to really understand as you're evaluating a child who's delayed and you're concerned for autism, is really looking for evidence of any abnormal eye gaze, any frequent use of route speech, limited use of toys, object attachment difficulties, low use of gestures, maybe low use of pointing, inconsistent response to calling off their name or other speech elements, and the use of nonsense or non-speech sounds. And so children who maybe have some developmental delays can have difficulty separating from parents, could have difficulties with transitions, difficulties with structures. They could have some rigid patterns, they could have some echolalia, but on its own, it does not equal that the child has autism. So in thinking about preschool and the qualification for preschool, a medical evaluation or diagnosis is not required before a child enters the preschool. And it is important to remember that you can approach your school district and express concerns about an impairment in communication, an impairment in any social interactions, or having restrictive interests and patterns of behavior as a reason for the team to evaluate and ensure that your child does not need services. So what we mean, again, I will reiterate it, just to make sure that we're all understanding what we're talking about, is what is impaired communication? Is a delay or absence of speech, a delay in nonverbal communication, echolalia, repetitive speech, poor eye contact, difficulty integrating with peers, and a very literal understanding of language. What we mean by impaired social interaction is inconsistent use of nonverbal communication, having poor joint attention, having difficulties with transitioning to new activities, having repetitive play and limited use of objects, poor imitation of skills, easy frustration and easy meltdowns, difficulties sharing and playing with others, a lack of social reciprocity and taking of turns. And what we mean by restrictive interests is unusual intensity or an interest in one object or activity. I think my favorite one is Thomas the Tank. Inflexibility, stimming or repetitive limb movements, preoccupation or fascination with certain sounds, phrases, and objects like fans or vacuum cleaners or washing machines, or trouble with shifting attention. So the tips for the educators, because I really find that the educators have really become, in my opinion, very good at picking out these concerns in children. It's really hoping that you are speaking to parents about the child's strengths and highlighting where they may have some weaknesses, Of course, not providing any labels, but rather explaining the domain or area that seems to be challenging for the child. If it's cognitive, it's speech, language, social, play, motor, adaptive function. Invite the parent to observe the child in the classroom setting if possible, or ask permission to provide a videotape at the end of the school day. I love it when educators are able to provide a brief summary of the concerns that they have seen in school, or they can share them with their own provider. I have to say, during COVID, there was certainly a lot of children that weren't able to see educators as often as I'm hoping they are now. If you're an only child staying at home and had a lot of these challenges, I really appreciate all of those educators who have been able to provide a note just highlighting these concerns, because a lot of first-time parents would not be able to figure these things out quickly. So I appreciate all of you that really take your time to do so. Some of the tips I have for parents is really inviting, if you have a child under the age of 3 who has any of these concerns, most of the programs, most of the states actually have an early intervention program. We have one here in New Jersey, and you can self-refer and speak about your concerns, either with speech or with social interactions. And of course, over the age of 3, we ask you to speak to your respective school district. Some of the barriers, and I think the challenges that we're all finding in terms of making sure that all children are identified as early as possible, is that after about 18 months, those visits to the pediatrician slow down because they're not getting as many check-ins and immunizations. Not all of the providers have knowledge or training in autism, so they may be a lag in terms of the referral process. There are long wait periods across the country with regards to seeing a behavioral pediatrician or a neurologist with autism expertise. A lot of cultural acceptance and bias for the diagnosis. Remember, I said that all cultures, all races have autism spectrum disorder within their community. And as far as we can tell, we do not think there is a difference. And so the fact that it seems like the studies showing a disparity between those that get diagnosed and when they get diagnosed, there's at least a 3 to 4 year delay in children from Brown and Black communities. There's also barriers to those with and without insurance, and barriers to those who speak a second language or have a low literacy level. So it is really important, I think, as I speak to educators, because you will touch every one of these children, no matter what kind of community that they come from. And certainly we know that boys are more likely to get diagnosed with autism compared to girls. And it's really because parents are more likely to report behavioral concerns in the boys. And if girls don't have behavioral concerns, they're more likely to be called shy, withdrawn, timid before they get the correct diagnosis. When it comes to treatment or trying to address the symptoms of autism, I put this on here so you can appreciate that there's a multitude of areas that the child may or may not be needing help in. There's obviously the core clinical features we talked about. There's associated neurological features between having seizures, having tantrums, sleep disorders, mood, anxiety, hyperactivity, inattention. And then there's also the secondary physical symptoms that we see with the immune dysfunction, the gut in terms of constipation or stomach issues, sensory disorders, sensitivity to light, sound, etc. The whole, I guess the basis of treatment really lies in surrounding that child with a multidisciplinary layers of treatment, which not only include behavioral programs, with ABA being the forefront of that, education and learning programs that are really directed at the child's needs. And they could be medications and other treatments that are also included in that. As you know, we really believe that autism is not one single disorder with one cause, and there's several environmental, genetic, and other biological contributors, and really understanding the child and trying to personalize and individualize the treatment is really going to be important as you take on treatment for the child. In conclusion, just a reminder that autism comes in all shapes and colors, and being on high alert for any identified impairments in communication, social interactions, restrictive and repetitive mannerisms, and really want to thank all of the educators out there who are able to make sure that our children get it identified early, and really speak to your medical provider or educator if you have concerns about your child, if there are parents in the audience. With that, I would like to share a few resources for those that are interested in learning more about autism identification, and perhaps modules and screeners that you could fill out, and we'll open it up for questions.